And so I'll be talking about penicillin and vancomycin, nephrotoxicity. Is it all a problem of diagnosis? And I think you would have had to potentially be missing out on a lot of Twitter feeds if you haven't heard about the controversies around penicillin and vancomycin co-administration. So I think given this is the National Centre for Antimicrobial Stewardship Journal Club, I want to just put into context where acute kidney injuries fits into the stewardship landscape. So I sort of think of antimicrobial stewardship in two parts. One is ensuring that patients need antibiotics, get the right antibiotic, and that antibiotic is optimised for them. And the other half is really the reduction of unnecessary antimicrobial use. And that reduction has two benefits. One is, of course, the reduction in antimicrobial resistance. We know every time we give our patients an antimicrobial, we run the risk of developing resistance in that patient. But the other big reduction that we can get from reducing unnecessary antimicrobial use is a reduction in adverse drug reactions. And that's not insignificant. There was a nice retrospective review back in 2017 in the States done by Tama et al, where they looked at about 1,500 people on a gen med ward and looked at their rates of adverse drug reactions to antimicrobials. And about 1 in 5 patients had an adverse drug reaction, and that included self-reported adverse drug reactions, and about a quarter of those related to nephrotoxicity. So within our stewardship antimicrobial practice, we also need to be practicing kidney stewardship. And I just want to make sure for everyone online that we're all on the same page about what an acute kidney injury or AKI is. The current gold standard diagnosis for acute kidney injury was produced by the KDIGO group in March of 2012, where KDIGO stands for the Kidney Disease Improving Global Outcomes Group. And they really merged the two previous AKI diagnostic criteria, which were Aiken and Rifle. And so now to meet the minimum criteria for an acute kidney injury, we have a serum creatinine that's either 1.5 times baseline, which is meant to be in a 7-day period, or these smaller increases of only 26.5 micromoles per litre over a 48-hour period. So if you've got a patient on the ward and they've got a creatinine of 70, and within the next 48 hours, they've got a creatinine of 100, they actually meet the criteria for an acute kidney injury, which has been linked to poorer long-term outcomes. Urine output, I would say in hospital, serum creatinine does the heavy lifting in terms of AKI diagnosis, because we don't reliably have urine output measures, but there is that urine output criteria there. And just to say that there, as the stage of AKI increases, as does the relative increase in creatinine, where stage 3 is considered more severe than stage 1. So I'll quickly touch on this because I just want to make sure everyone agrees with me. This is the beauty of being the presenter. You get to sort of put your views forward and hope everyone agrees with you. But acute kidney injury is really significant for patients. And I just want to spend a little moment on that. So the negative outcomes that can be seen by patients do depend on the type of AKI. It's a really heterogeneous clinical syndrome. And the risk of AKI can be determined by the severity of AKI, the duration of the AKI, the underlying patient characteristics, so causing an acute kidney injury in a patient who has pre-existing kidney disease. And even the cause of the AKI can have some association with the negative outcomes. So AKIs in the ICU or AKIs following cardiac surgery may be more significant than drug-induced AKIs, though we're not sort of completely sure about that yet. Just to quantify that a little bit, there was this lovely systematic review and meta-analysis done by a doctor from Melbourne, Dr. Emily C. in 2019. She looked at over 82 trials and got almost 2 million patients worth of data. So she's got these really great risk or hazard ratios for 3 of the major negative outcomes we have after an AKI, which is death, end-stage renal disease, and chronic kidney disease. And you can see there, even with a stage 1 AKI, risk of mortality is increased 1.34-fold. And because of the huge patient numbers, the confidence interval is really tight around that, and it is significant compared to not having an AKI. And you can see the risk there for end-stage renal disease and chronic kidney disease is significant and increases with the gradient of AKI severity. And just one other thing that I hadn't really thought about before undertaking my PhD in this was that the duration of AKI probably matters as well. And actually this has played out in the Clifton literature. but certainly this is only stage 2 or 3 AKIs, so the more significant ones in ICU. And you can see if you've got an early sustained reversal of your AKI, that top green line, at 1 year your survival is very high. But if you've got a stage 2 or 3 AKI that never reverses, that red line down the bottom, your survival at 1 year is less than 40%. And it's just interesting whether or not we should be chasing the creatinines and trying to minimize them. So many antimicrobials cause acute kidney injury. I'm sure that's of no shock to anyone here. We think of acute kidney injury normally as acute interstitial nephritis, and that's that top box here, if you can see my cursor. So yeah, trimethoprim sulfamethoxazole, fluoroquinolones are a fairly unusual cause, probably less than 5% in case studies. I think the maximum is 9% in a case study, and really driven by ciprofloxacin. So vancomycins, we think of penicillins and cephalosporins as predominantly causing acute interstitial nephritis. I can't really get interested in clindamycin. I don't think it causes a lot of AIN. One of the other drugs that does cause an acute interstitial nephritis that's dose dependent, so something we could potentially have a bit of input in is rifampicin, that happens in that hemolytic anemia sort of hypersensitivity syndrome. The other main type of AKI is acute tubular necrosis. We think of vancomycin and its dose exposure relationship being related to acute tubular necrosis. And some of the other antibiotics there. And then there are AKIs from other mechanisms and some drugs that cause crystal nephropathy, particularly in the setting of dehydration. I will just say that acute interstitial nephritis that we see with vancomycin and the beta-lactams tends to be fairly idiosyncratic, whereas the acute tubular necrosis from vancomycin we definitely think of being the dose-dependent AKIs that we've seen with the increases in trough concentrations over the years. Okay, so camera 2, I'm not sure how familiar the audience will be with camera 2. Some people will be very familiar. So camera 2 was a big trial undertaken with Australian researchers and internationally, looking at whether or not adding an anti-staphylococcal beta-lactam to standard of care for MRSA bacteremia helped treat infections better with microbiological and clinical outcomes as the primary outcome. It recruited from 2015 to 2018 and was stopped early because of this surprise finding of an increased risk of acute kidney injury in the combination therapy arm, which was predominantly driven by flucloxacillin and vancomycin combination. And what's really interesting about that is the standard therapy arm is predominantly vancomycin. So this is an increase in nephrotoxicity compared to a known nephrotoxin. So this was a really unique finding, and unfortunately there wasn't any benefit in the primary outcome that made them want to continue the study and really led us down a path of trying to investigate what's going on here. We have done some further analysis on these data since then. I really love this graph that was produced by Louis et al., which is a group of collaborators in the States. And they looked at the risk of acute kidney injury related to the vancomycin 24-hour area under the curve, AUC. So across the y-axis here, we've got the probability of AKI, and the x-axis, the vancomycin 24-hour AUC. So we can just think of that as a marker of exposure. And you can see for both the red and the blue line, as the 24-hour vancomycin AUC increases, the risk of the probability of AKI also increases. Really just hammering home that vancomycin is a dose-dependent acute tubular necrosis. The interesting thing is the red line is just the vancomycins on their own, and the blue line is the flucloxacillin or cloxacillin in combination with vancomycin. And so for any given AUC, the risk of acute kidney injury is increased with the addition of flucloxacillin or cloxacillin to vancomycin, and really nicely delineated here with these data. Similarly, from Legg et al., my first PhD paper, real thrilled to cite yourself in a talk, I must say. We had a look, so we took the camera 2 data and tried to look at the clinical covariates and just make sure there wasn't some huge discrepancy between the groups that was also driving that acute kidney injury. Now, it was a randomized clinical trial, so we didn't find anything. What we were able to do was quantify the risk. So flucloxacillin, in addition to vancomycin, increased the risk of AKI over 4-fold. And the only other significant predictor of AKI was the vancomycin AUC. So no AKI had a median AUC of 400, And unfortunately, the AKI group had a median AUC of 461, which is well within the current IDSA guidelines of 400 to 600 as a target AUC. So the other thing that was happening at that time was that piperacillin, tazobactam, and vancomycin was getting published repeatedly in observational studies as causing an increased risk of nephrotoxicity in combination with vancomycin. And I think we all started asking ourselves, is there something about penicillins in combination with vancomycin that kills your kidneys? So the first thing, I think, although this doesn't obviously relate to fluclox, but could it be the beta-lactamase inhibitor? So there was a study from Sarah Alisami from the States, looking at piperacillin tazobactam with vanc compared to ceftolozane tazobactam with vanc, where the tazobactam was consistent across two groups. So you would expect the risk of AKI to be the same if it was being driven by the beta-lactamase inhibitor, but they didn't find that. They found, as everyone found, that the addition of piperacillin tazobactam to vancomycin increased the odds of AKI, and surmised that the AKI is not related to the tazobactam. So let's just put the beta-lactamase inhibitor out of our mind for now. And then let's think about penicillin nephrotoxicity and whether or not this is a class effect. So methicillin actually is what really got it removed from the market. We know that nafcillin causes more nephrotoxicity compared to oxacillin. This was a review from the reports of adverse drug reactions to the FDA. And you can see, compared to oxacillin, when nafcillin and oxacillin are compared, for lots of things, the risk is very similar. So rash, hepatotoxicity, neutropenia. But you can see this huge divergence in the risk with nafcillin really being a much, it's got this higher reporting odds ratio for acute renal failure compared to oxacillin. So again, really highlighting that the penicillins maybe shouldn't all be considered the same here. Flucloxacillin, Jason Tribbiano et al. Did a lovely review of people with biopsy-proven AIN from a variety of sources, and flucloxacillin was the most commonly implicated penicillin there. And just a question I get asked all the time and I don't know the answer to is, could it be a dose-dependent effect? There's a single study looking at surgical prophylaxis of antibiotics where higher doses of flucloxacillin were associated with more nephrotoxicity, but it was in combination with gentamicin, and it's probably not enough to draw any conclusions from yet. The next question, and probably my favourite thing at the moment, is why are some penicillins more nephrotoxic than others? And I think this comes back to kidney transport proteins and whether or not the beta-lactam gets into the proximal tubular cells, whether it gets stuck in the cell, and whether when it's in the proximal tubular cell, does it cause toxicity? So the kidney transport proteins line the two borders of the proximal tubular cells. They're responsible for secretion of drugs and creatinine. We know about 10 to 40% of creatinine is subject to that active tubular secretion. They can facilitate toxicological effects by uptake of drugs into the tubular cells. And then particularly if drugs have got a slow efflux, they can get stuck there and cause their toxicity. And we know that for beta-lactams, their uptake into the cell is likely related to OAT3, which is an organic anion transporter. I guess it's the third one they found. And we also know from some nice in vitro studies that different penicillins have different interactions with OAT3. So there are some non-inhibitors, there are some weak potential inhibitors, and it's probably related to some specific drug properties. So having a certain number of hydrogen bond donors, having a lower total polar surface and a greater lipophilicity can increase your likelihood to interact with these receptors. And I think we've been here before when we're through the allergy literature, where we really are quite comfortable now knowing that different penicillins behave differently, and probably this is no different. So because this is a journal club, I wanted to just really highlight this paper that came out last year by Todd Miano, another pharmacist, that I think really helps to clarify maybe what we should be thinking about when we see increases in creatinine. Anyway, we'll go through the paper and I'll be more articulate. So the paper was called The Association of Vancomycin plus Piperacillin tazobactam with Early Changes in Creatinine versus Cystatin C. It says it's a prospective cohort study. It was part of an ongoing bigger sepsis project called Menzies, and they had two groups for analysis. So they had quite a big antibiotic group that they just looked at the risk of vanc and pip-taz versus vanc and cefepime. And then they had a smaller group where they were able to look at serum cystatin C, but people had to have the right plasma samples stored to be in that cystatin C group, so that was a smaller cohort. It included patients on vancomycin, which is the VPT, or vancomycin, which they thought was an appropriate comparator, for 48 hours or longer, with each drug initiated within 48 hours of ICU admission. So all these patients were in ICU, I should have said that, sorry. One of the sticking points was that these patients had to have had 2 plasma samples, so one in the 24 hours before the index date, which was the date that the 2 antibiotics were started, and one in the 24-hour window after the combination therapy had been going, to allow for these clean comparisons. And they looked at kidney function biomarker concentrations, which was creatinine and cystatin C, compared from index, so 24 hours before the combination therapy was started, and at day 2, and they had these stored plasma specimens. And they had a couple of secondary outcomes, so creatinine defined AKI through to day 14, dialysis, and 30-day mortality. So some pretty relevant outcomes there. Let's quickly talk about cystatin C. So the reason they've used cystatin C is because of the limitations of creatinine. And again, if it's, I'm sure that again the audience is well aware of this, but just I guess 2 things to highlight. Creatinine is affected by things other than renal function, so dietary intake of creatinine. Dietary intake of protein can lead to a creatinine spike. And similarly, 10 to 40% of creatinine is tubularly secreted. So you can have blockade of its tubular secretion, causing an increase in creatinine concentrations, which is unrelated to true kidney injury. And a couple of things about that. We do know, a nephrologist told me, that as your GFR decreases, these tubular interactions, or these competitive inhibition interactions, become more significant. And the other thing is, I guess when you've got an interaction that's caused by competitive inhibition, you'll see the increases in creatinine fairly quickly because they'll happen straight away. Because of the limitations in creatinine, people are looking at other ways of diagnosing AKI, because you can have increases in creatinine unrelated to true kidney injury. So this is a busy slide, and I apologise, but just to highlight, there's a bunch of these coming through. There are 3 types of novel biomarkers. So there's stress markers. This second one here, TAMP2, IGF-BP7, is more commonly known as nephrocheck, and it's a cell arrest inhibitor where it seems to be released at the first sign of kidney stress, when the cells are starting to arrest their growth because they're worried about damage. There's these damage markers that are released from the kidneys in relation to damage, so coming directly from the source, makes us feel like they could be very reliable. One of the best ones is kidney injury molecule 1, which is commonly abbreviated to KIM1. And then there are the functional markers of cystatin C, which is freely filtered, so it doesn't undergo this tubular secretion, and proencalphin A, which is not commonly used. So just a little diff here that might make your kidneys hurt, but this is the, after a kidney injury, the localized biomarkers are released and can be detected in the urine. Just finally, quickly to say, the different biomarkers are released from different areas. And so KIM1 is particularly good for vancomycin because it's released only from the proximal convoluted tubules, which is where vancomycin causes its acute tubular necrosis. So quickly back to Miano et al. They did some lovely statistical analysis where they used inverse probability of treatment weighting for adjust for confounding between the vancomycin and the vancomycin groups. And then they assessed changes in biomarker concentrations roughly in line with KDIGO, so looking for 50% increases, and they used the weighting in the model. So just in terms of the weighted cohorts, I think it's quite interesting. So they had an unweighted cohort and then a weighted cohort. So if we use the index GFR here, in the vancomycin group, people actually had a bit of a lower index GFR compared to the vancomycin group, with the sum of mean differences being almost 0.1. And then they applied the inverse probability of treatment weighting to normalize the patients. And so they're able to, perform the statistical wizardry that normalizes things and then reduces the sum of mean squares, sum of mean differences, sorry. So the things that were different between the two groups before they waited were severity of illness, baseline GFR, presence of cirrhosis, and lactate is another good example here, where the unweighted cohort did show a difference, where the Vancomycin group had a higher lactate than after waiting, much more normalised there. So there is interesting that probably the type of patients that get Vancomycin are different to the type of patients that get vancomycin. But they were able to adjust for that with this inverse probability of treatment weighting statistics. So what did they find? So they're looking at a bigger antibiotic cohort of 793 patients and a smaller cystatin C cohort of 192 patients. They found that vancomycin was associated with significantly higher average creatinine concentration and a higher frequency of increases greater than 50%. In contrast, they found that vancomycin was associated with a non-significantly lower average cystatin C and a similar frequency of cystatin C increases of greater than 50% across the groups. Vancomycin was associated with a higher creatinine diagnosed AKI, but this was attenuated with their weighting and non-significant, particularly when only including stage 2 or above. And you can imagine that, again, if we're thinking that this is being driven by a competitive inhibition, that you are more likely to get those stage 1 AKIs related to the 10 to up to 40% of creatinine that's going to be blocked by that competitive inhibition. And the vancomycin was not associated with the more clinical outcomes of dialysis or mortality after the waiting. So I feel like the cystatin C is really putting a bit of doubt in our head about whether these increases in creatinine are true kidney function, true kidney damage, apologies. And the other thing that's really interesting about this is that they've used this weighting to help us see that there might actually be differences between the two groups that the observational studies would really struggle to account for. I do have a couple of tables here. I'll just really quickly go through this. So I guess the interesting thing here is the percent difference from index to day 2 for these biomarkers. So the cystatin C from baseline to day 2 was actually lower. The only thing that was increased was creatinine. The other biomarkers were not significantly increased from day 0 to day 2. I might just quickly skip over that one. But I think the question is why the creatinine versus cystatin C discrepancy. And so again, it's time to talk renal transport proteins. So these are little creatinine markers in the proximal convoluted tubular here. We've got the basal membrane with blood and the apical membrane into the lumen with urine here. So what's happening is creatinine, the tubular secretion of creatinine is facilitated by OAT1 and OAT3 and probably a little bit of OCT2. So this is organic anion transporter and this is organic cation transporter, but they're actually fairly promiscuous and they'll do anions and cations. But what happens is piptaz blocks OAT1 and OAT3, or piptaz uses OAT1 and OAT3 to get into the proximal tubular cell itself, and it binds very tightly to those, and so does tazobactam. And vancomycin is blocking OCT2, and all of that means that creatinine can't get into the renal cell to get secreted, so it's coming back potentially into the blood and looking like a creatinine spike when it's just related to blockade of these enzymes. The other thing that is interesting is Vanc actually also suppresses OAT1 and OAT3, so there's less of them, which may be why we get these creatinine rises with Vanc and piptaz that we may not necessarily get with piptaz alone. So that suppression of the OAT1 and OAT3 means that there's less renal transporters, and then the ones that are there, the piperacillins, got a higher affinity potentially for the creatinine, and so is blocking their use. While we're talking about biomarkers, while we're talking about renal transport proteins, I just thought I would just flex a little bit because I've learned so much about them. So one of the biggest advances we made in terms of reducing gentamicin nephrotoxicity is start to give it once a day. So gentamicin exerts its nephrotoxicity by being reabsorbed into the PCT using the megalin-cubalin complex. But the megalin-cubalin complex gets saturated. So we give gent once a day, smaller amounts can get in and the rest just passes through and is excreted. The other one is cidofovir, which is super cool. So it has this problem where it's uptaken really well by O1 and O3 into the PCT and gets in and is a happy time. But actually it has quite a slow efflux. So it builds up in the proximal tubular cell and that's why it's causing toxicity. So we give probenecid, which wipes out O1 and O3, stopping the cidofovir from building up in here, giving us a nice boost to our levels and decreasing the nephrotoxicity. Okay, so just got a couple of quick slides to finish, apologies. I hope this has all made sense so far, but essentially it's not entirely clear what the mechanism of injury is and whether it's real and whether all this stuff for piptas and fluclox is the same. So I'm going to lean on some of my colleagues in the States who have been doing a lot of interesting work with rats. And I think the rats can teach us a lot. And I've been very grateful to be in discussion with Mark Sheets, who's the final author here. And he's taught me a lot about what he's found. So this was a paper in AAC in 2022. It's looking at a rat model where they gave vancomycin and vancomycin plus piptas and looked at the urinary biomarkers of the rats. So this is a really nice graph here. We've got our KIM1 concentrations, and you can see here vancomycin saline is causing quite a bit of nephrotoxicity. All the rats get 150 milligram per kilogram per day, which is a allometrically scaled dose. But you can see here again, really no toxicity in terms of the vanc and piptas. And these rats are still getting vanc. So you would expect a similar rate actually. So these authors actually concluded that piperacillin tazobactam is protective against vancomycin-induced acute kidney injury, because one of these things about these renal transport protein interactions is that you're actually stopping sometimes the drugs from getting into the renal cells. So increasing your creatinine, and you're probably stopping a little bit of vanc getting in there as well. So, you know, a really out of the box finding from the rats here, but certainly not an additive nephrotoxicity. Maybe more what we would have expected to see was the same group did a similar study back in 2020. And if I can just direct you to the KIM1 graph here, you can see that for saline, very low rates of KIM1 expression over the days of exposure. Piptas, very low rates of KIM1 exposure. Vancomycin, you can see an increase, you know, from day one, suggesting nephrotoxicity. And for piperacillin tazobactam and vancomycin, it does still occur, so the vancomycin nephrotoxicity is shining through here on day 3, but maybe it's a delayed presentation due to some blockade by the piptas. Really interesting is the fluclox rat addition. So this was just a poster at ECCMID last year and it is going for publication, but it tells a different story. So this is the KIM1 graph here, where you can see again saline very low levels of biomarker excretion, fluclox very low levels, vancomycin high levels, and fluclox potentially, vanc and fluclox potentially even higher KIM1s than vancomycin alone, really contributing to this narrative about additive nephrotoxicity. And what they were able to show is that the concentration of vancomycin in the kidney tissue is higher in rats with the vanc and fluclox group compared to vanc alone. And I strongly suspect in my heart that this is going to be related to some renal transport interaction where potentially, as opposed to piptas, which blocks it, maybe fluclox lets it in, but I really need some basic scientists to help me prove that. And again, you can see the urinary log 10 KIM1 with this, again, fairly nice differentiation where the vanc KIM1s finish and the vanc fluclox KIM1s start. So again, really highlighting potentially a true additive nephrotoxicity, at least in rats. So their conclusions were that the combination of vanc and fluclox was demonstrated to cause more AKI than vanc alone, very interesting, rat model, and there was an accumulation of vancomycin in the kidney tissue. Okay, so I'll summarise there. Just to say, AKI is a significant clinical syndrome for our patients. I think the risk of AKI varies in different penicillins, and I think we're very comfortable with that because of the allergy literature. Even though the vancomycin story may be one of competitive inhibition, I just really want to make sure that a couple of key points. One, these patients are still getting vancomycin, which is a known nephrotoxin. So they are still at risk of acute kidney injury. And there is probably something about the type of patient that gets vancomycin that's making them at high risk of AKI. So I really don't want the narrative to be that the vancomycin additive, that vancomycin doesn't cause nephrotoxicity. I think all the patients that get vancomycin still need to be at least on the same alert that you would have for any patient on vancomycin, and potentially even a little bit higher, because there do seem to be a cohort of patients that do get nephrotoxicity. I think the flucloxacillin and vancomycin is a story of a true drug-drug interaction where there is additive nephrotoxicity. Creatinine is limited, urinary biomarkers are wonderful, and I'm hoping to do a study looking at urinary biomarkers as a sub-study of SNAP, but that's a talk for another time. And apologies, I went slightly over, but thank you very much for listening.
Thanks so much, Amy. I'm really looking forward to how you progress with the urinary biomarker work, and hopefully we can have you back next, like in a couple of months or maybe next year with all your new findings. So thanks again. Kaz just had to step out to take another phone call. Moving on, I will just have save questions for at the end in the interest of time. But a big thank you to Sonja and Tom for the work on their presentation, Scabies and Antimicrobial Stewardship in the top end. Take it away, Sonja.
Thank you. I just wanted to start by saying that was a really great talk, Amy. Amy worked in AMS in the Northern Territory at the top end for 3 years with us, and so she's a good friend of mine, and I'm really excited to see how she's going with her PhD and all her findings. I just wanted to acknowledge that there's a lot of people that put work into AMS, infectious diseases and scabies management in the top end, and I've tried to list some of the people here. I work in a really special place, and I just want to acknowledge the country on which I work. In the spirit of reconciliation, I acknowledge the traditional custodians of the land where I live, the Larrakia Nation, and I pay my respects to their elders past, present and emerging. This map on the screen is a visual reminder of the cultural richness and diversity of First Nations Australia in the top end. There are over 100 Aboriginal languages and dialects spoken in the Northern Territory, and many people have English as their third or fourth language. 70% of people who access Northern Territory health services are First Nation, and half of NT First Nations populations live in remote or rural areas. So it's a really special place to work and has a lot of different challenges compared to working down south. So AMS and the top end. The top end has some of the worst antimicrobial resistance rates in Australia. So our antibiogram demonstrates this. So particularly in gram negatives, we're getting slow creep with ESBL and loss of gentamicin susceptibility. And as we take antibiograms every year, we can see this slowly happening over time. Interestingly though, we have very high rates of NMMRSA in the top end in our staff. And that's pretty much been stagnant over the last 10 years plus. I would also note that Central Australia has more NMMRSA than we do. We also have environmental pathogens in the soil and water not seen elsewhere in Australia. So I'm just going to sprinkle a little bit of milioid on my screen. And the infectious diseases epidemiology changes whether it's wet or dry season. So Burkholderia pseudomallei, as many of you know, is a gram-negative bacillus that's found in the soil and water, and in periods of heavy rain and flooding, it proliferates without the UV light killing it, and also, in response to water. And humans are exposed to it by percutaneous inoculation, inhalation, aspiration, or ingestion, and the most common site of acute infection is in the lungs. It usually affects adults who have risk factors for immunosuppression, and it can cause severe infections and has a 90% mortality rate untreated. So we work pretty hard to make sure that we think about milioid, particularly in wet season when people present really unwell. We also have Vibrio and various other gram-negative nasty organisms in our water up here, which causes really nasty necrotizing infections. And we also have crocodiles. And we actually have a crocodile bite guideline because we have crocodile bites and we need to know what the best antibiotics to give in a rapid manner. And as I said, we have a lot of MRSA, and because it produces PVL toxin, it causes a lot of pus because we have the ST93 dominant MRSA clone up here, and also we have PVL in our MSSAs. We also have much higher rates of sepsis than the rest of Australia, and we have a high staff turnover. So those are the sort of challenges in which we work. So our AMS service, we have a decision support tool in the top end, and in Central Australia, which is really, really important because, as I showed you before, our antibiotic requirements are slightly different to the rest of Australia, and that's called TEAMS. And it has demonstrated published reductions in antimicrobial usage. So the Aura report in 2019 gave it a bit of a shout out. The other thing that we do that's slightly different is we have remote virtual rounds in the top end. So we have virtual rounds within the hospital and in Royal Darwin, but we also have virtual rounds out to our remote hospitals from Darwin. It's weekly and we really enjoy it. So it's run by Tom and I, my amazing AMS pharmacist who's also online, and previously Amy and Jen Collins and Jeff were pharmacists involved in this. And we talk to the regional hospitals and they have a really good showing. So it's usually a clinical pharmacist, all the junior doctors and senior doctors on the ward on general medicine and surgery attend, and it's a really lovely collaboration. It's been an overwhelming success. So we have shown that 96.2% of all AMS team recommended restricted antibiotic recommendations are followed by the treating team within 24 hours. And there is consistently excellent NAPS reports from the regional hospitals. And that is the lovely Richard Budd and from Catherine Hospital, and below is the wonderful team at Grove Hospital at the moment. We also do a little bit of infectious diseases teaching on the run during our talk. So it's a really nice collaboration, and we have collaborated over many things. So IV to oral audits, surgical prophylaxis. We've done sepsis awareness week activities, and interestingly, crusted scabies has become an interesting focus of late. So scabies in disadvantaged communities in the tropics. Sorry, just not up to date with my notes. So up to 300 million people worldwide have scabies at any one time, and the prevalence in the tropics is really high, with up to 50% of children at any one time having scabies, and adults up to 25%. Scabies underlines 50 to 70% of all streptococcal pyoderma, which results in multiple overlapping epidemic cycles, which I'll get to shortly. We also have core transmitters with hyperinfestation, so crusted scabies, which are important in some communities and particularly in the top end. So these patients with crusted scabies have millions of mites on their skin, and they transmit scabies, perpetuating the cycle in the community. Scabies is particularly endemic in the Northern Territory, and actually impetigo from scabies is the highest in the world in First Nations children in the Northern Territory. So 49% of children surveyed had impetigo when they had a look at all the meta-analysis from this study that's on the screen in 2015. So there's extreme burden of scabies and skin sores in infants in remote First Nations communities. So this study done in 2008, there was data collected from birth for 126 children. 73% of those children presented to the clinic at least once with scabies in their first year of life, and 86 presented at least once with skin sores. So why is scabies important? Well, as I just said, the scabies infection and skin trauma and damage promotes infection with group A streptococcus and pyoderma. And this has lead-on effects to cause acute post-streptococcal glomerulonephritis, acute rheumatic fever, and later rheumatic heart disease. It causes long-term health problems for First Nations people. And of course, invasive group A streptococcus is a really severe and significant illness. Scabies infection typically involves fewer than 15 mites and is often in the webbing of the fingers and in the wrists in adults, and in children it's often on the feet and on the face, and that's also the case in elderly people. So the extreme of age, it's slightly different presentation of simple scabies than adults. Crusted scabies, however, have millions of mites in hyperkeratotic skin and scales that involves much of the body surface area. So scabies treatment, you may have heard that permethrin and oral ivermectin is now equal first line on PBS and therapeutic guidelines, and on the most recent therapeutic guidelines that was published last year. And this was a response to the RISE trial done in Solomon Islands, and also trials done in Fiji, which showed that they were equivalent. But we also use other topical therapies such as benzoyl benzoate and chromatidone in children. The scabies mite is a bit tricky. It undergoes 4 stages in its life: egg, larvae, nymph, and adult. And development of the egg to the mature adult takes 10 to 13 days. Now, this means that that's tricky because ivermectin, unfortunately, is active against the mite, and same with permethrin, but not the eggs. And so repeated doses are recommended to kill the newly hatched mites. So it means it's difficult to get rid of quickly. You have to dose people multiple times. Our ivermectin dosing regime is 200 micrograms per kilogram per dose, and we round up per kilogram, not down, and we give ivermectin with food. So for ordinary scabies, we use 2 doses, so day 1 and day 8 to 15. But for crusted scabies, we give more doses according to how severe the crusting is, and I'll go through that in a second. We also, at the same time as the ivermectin, give a topical scabicidal therapy and a keratolytic therapy as well. So we're killing the scabies in 2 ways, so topically and orally, and then we're also giving keratolytic therapy to get rid of all the scale. And this was published, scale according to grade of crusted scabies has been published in 2013 by Josh Davis with Bart Curry. And we look at distribution of the crusting and shedding, past episodes and skin conditions to give a grade, and therefore we give a treatment course, so how many doses of ivermectin this person will have, how many doses of the keratolytic agent and topical scabicidal therapy that they will have as well. And this has been, a great intervention, this guideline with treating crusted scabies with this aggressive management. We have shown that mortality has dropped with this guideline-based aggressive management. However, still 10% of patients who come in with crusted scabies have Staphylococcus aureus bacteremia, which is very, very significant. And there is still a significant burden of crusted scabies on hospital bed days and costs. So isolation rooms are used, PPE for staff, and adverse effects of isolation on the patients as well. There seems to be a genetic predisposition to development of crusted scabies, and we need further studies into why people develop crusted scabies so frequently. So back to the AMS virtual round. So we noted 2 patients on the ward via the virtual round. So patient A was noted to be recurrently admitted with brief periods in between, and she'd had 60 admissions since the age of 15, and she'd had a total of 2.5 years spent in hospital as an inpatient. And what was really worrying was there was increasing frequency of the admissions. So she'd spent the most of 2021 as an inpatient, not clearing her crusted scabies in early 2022 despite treatment. And then we also noted a second patient, patient B, who'd had 115 admissions, and she had spent a total of 4.5 years spent in hospital as an inpatient. And why is that? Well, there's multiple reasons, and I'll go into a little bit more, but obviously shame is a big part of why people don't clear crusted scabies. It's a disfiguring condition. Having somebody help you wash and apply cream vigorously every day and sit in an isolation room is a really big ask of people. Cultural commitments as well. People often need to leave to attend certain ceremonies or to look after certain people in the community. And of course, the poor access to home environment to support skin health. So we scraped these 2 patients. The first one was this slide is for the first patient, patient A. So her skin was gently scraped into a plastic container. Megan Yanakouris up on the top there did the reconnaissance mission. The mites have to be kept relatively cool and have some moist paper cloth in a jar so that they don't desiccate. They have to stay away from sunlight as well, so they're a little bit sensitive. So Megan made what she called the Scabies burrito, and her children apparently named all the Scabies mites, and this was put into an esky. And then she got onto a plane and rushed over to Menzies. Let me see if I can play this. So you can see the mites are very active. And this particular scraping had a lot of nymphs as well. There we go. Okay, oops, sorry. So in 3 hours and 15 minutes from skin scraping, the mites arrived in the Menzies lab, and the wonderful Deb Holt set them up on multiple different plates. So, so one had the ivermectin dosed, diluted to 100 micrograms per gram. One had benzobenzoate, 25% into a petri dish, and one had permethrin, 5% into the petri dish, and there was a negative control, which was the emulsifying ointment, British Pharmacopoeia 88, if you want to know. The live mites were put on the plates overnight, and the ivermectin plate, the mites were still alive in the morning, wriggling their legs. The negative control, they were still roaring around in the morning, and the benzobenzoate plate, they were dead within half an hour. So we then knew that this lady had ivermectin resistant crusted scabies. The second lady that I mentioned before, also when we brought her scraping across, she had benzobenzoate resistance noted. So how does ivermectin work? Well, it has its peak at 4 to 6 hours and a half-life of 1 to 2 days. It acts on glutamate-gated chloride channels with resultant persistent chloride influx, paralysing the muscles and nerves in nematodes by hyperpolarisation, but we're not really sure how it works in scabies mites. We think there's probably effects on the pH-gated chloride channels, and perhaps resistance occurs with mutation of these chloride channels. There's also a possibility that there's efflux pump abnormalities. So the P-glycoprotein efflux pump regulates the concentration of ivermectin in the cell. So as you know, in vertebrates, the drug pump of the PGP family exclude the drug from potential sites of action. So that's why if you give ivermectin to adults, we don't tend to have neurotoxicity, but there were border collies that were found to get neurotoxicity with ivermectin, and they were found to have a PGP mutation. In scabies, there may be PGP polymorphisms or absence of the PGP, and we're not sure if resistance occurs from drug inhibition of the PGP efflux pump or PGP polymorphisms. I would say that drug inhibition includes rapamyl cyclosporine protease inhibitors, ketoconazole, tamoxifen, and midazolam. So in the NT, we have shown this is not the first documentation of ivermectin resistant scabies. The first one was documented actually in 2000, and that was with a patient who'd actually had benzoate resistance now. That lady in 2000 actually had ivermectin resistance. She was the first patient. So it just paints a picture of somebody who comes into hospital frequently, gets reinfected frequently, has a really hard time clearing her crusted scabies, and then gets reinfected pretty quickly as well. And she'd had over 200 doses of ivermectin over 15 years when she developed crusted scabies with ivermectin resistance in 2000. And the wonderful Kate Mousey did a study looking at the longitudinal evidence of increasing in vitro tolerance of scabies mites to ivermectin in scabies endemic communities. And she showed that the mite survival time in the presence of in vitro ivermectin doubled over the 10-year study period. So we need to watch really closely from ivermectin resistance now that ivermectin is equal first line to permethrin. So that's just something that we just need to watch really quickly, really carefully. So what happened next? So this patient A was transferred to Lorraine Brennan Centre, which is a part of Royal Darwin Hospital. It's a very, very nice facility where there's gardens and people can sit outside, and they have basically their own studio apartment. And she had a regimen of topical therapy only, so no ivermectin, benzoyl benzoate and tea tree oil alternating with the keratolytic agents. And she ended up clearing actually in 3 weeks. With intensive community support, she had new mattresses, bedding, plumbing fixed in the house, a new washing machine, and all her family treated. And she remained out of hospital for 5 months, which we were very, very happy with. And she's been readmitted now, again, with crusted scabies. There's currently a working group coming together to have a coordinated approach for each of the crusted scabies admissions. So we're looking at CDC, the infectious diseases and AMS team, remote hospital teams and community health teams coming together to manage each crusted scabies patient. So why is scabies so hard to eradicate? Well, I explained that they have this prolonged cycle over a couple of weeks from, egg to adult. So that makes it tricky. You can't give just one dose of drug at the moment. Secondly, scabies can be a bit hidden. So in children, it's often on the palms of the feet, and elderly people sometimes underneath nails, for example, skin folds on the genitals. So it's sometimes not picked up easily. And then 3, we've got the crusted scabies, the hypertransmitters in the community. So people who have crusted scabies and have millions of mites on their skin, shedding. And then 4, we also have a very mobile population in the Northern Territory. So people can receive treatment and then get reinfected pretty quickly when they move around to a different community. So there has been previous attempts at mass drug administration with ivermectin for scabies control. This one in 2015, which was done in the Northern Territory, there were over 1,000 participants seen at each population census. The scabies prevalence fell from 4% at baseline to 1% at month 6, but prevalence rose to 9% at month 12 among the cohort in association with exposure to a crusted scabies patient. So what we don't want is to have ivermectin resistant crusted scabies patients in the community giving people scabies. And also the prevalence of 14% were noted amongst the new entries to the cohort, so people who were coming and going from this cohort of patients. So the success of mass drug administration is limited in highly mobile populations where reintroduction of scabies in the community occurs from newcomers and return community members who have not been treated. So the diagnosis and treatment of crusted scabies in the Northern Territory and prevention of recurrent cases is a critical consideration prior to any future mass drug administration trials. So this is the beautiful Deb Tilakaratne, our dermatologist up here, and he's looking into moxidectin. So moxidectin is 100 times more lipid soluble than ivermectin and distributes to a greater degree into fat. It has a much longer plasma half-life of 23 days. So that's really exciting. It could kill the scabies after they hatch. It has less affinity to PGP than ivermectin, so there's more potential for neurotoxicity in vertebrates. So we have to be super careful that we get the dosing right and we don't give people neurotoxicity. And it's generally recognised that a resistance to ivermectin will confer resistance to moxidectin. So we do not want a lot of ivermectin resistance before we hopefully get a moxidectin trial for mass drug administration. So Deb currently at the moment is working with Menzies to work out the best dose for killing scabies. And so far 8 milligrams isn't the best dose. We've got to go up, but it's just got to be carefully done so we don't give neurotoxicity. And then finally, obviously, the fifth issue as to why scabies are so difficult to eradicate is primordial factors. So the primordial prevention of scabies, pyoderma, acute rheumatic fever, rheumatic heart disease, post-streptococcal GN, and antimicrobial resistance, because it's happening, is poor health hardware. So poor housing, poor access to education, employment, communications, and transport and access to services. So a lot of people live in very crowded situations in the Northern Territory, and a lot of people have poor housing in the Northern Territory and don't have the ability to wash themselves and wash their clothes on a daily basis. Antimicrobial resistance in bacteria is spreading in these situations. We can't see it; it's not as obvious as scabies or crusted scabies, perhaps, but it's happening. So on a positive note, steps forward, the Barunga Laundry. So that was a community laundry service that's been set up in the Barunga community just outside of Katherine, has had really, really positive influence on the the amount of scabies in the community, and we're hoping to get some funding to set up some laundry services in some of the other communities in the top end, particularly the regional hospitals where there's cluster scabies patients. Also, the federal government has committed to $100 million towards boosting housing and essential services for the Northern Territory. It's a drop in the ocean for what's really needed, but it is still a step forward. And I'm also very interested to see what's going to happen with this. They're doing an ivermectin mass drug administration in the Solomon Islands, which will be the entire Solomon Islands. Everybody will get 2 doses of ivermectin. So I'm really, really interested to see what happens with that trial. Obviously, I'm hoping that we find out a good dose for moxidectin so we can do our own trial, but we'll be learning a lot, I think, from what happens to the in the Solomon Islands. And that's the end of my talk. Does anybody have any itching questions? Sorry, that's my partner told me to ask that question.
Feel a bit itchy now.
I've had scabies, it's itchy. It is horrible, you know, it's an awful thing. And I feel very sorry for people that live with it as part of their daily life. It's terrible, actually.
Thank you, Sonja. Yeah, like you said, it seems like there's a lot of other factors than just giving a drug. Like, you know, how do you prevent infection in the first place? And then like this slide you've got here about the mass treatment in Solomon Islands. So do you think that will have much of an impact? I mean, like you said, it's not really addressing all the other factors that you've mentioned.
In the Solomon Islands, I lived there actually a few years ago for a couple of years. There's the thought that they're not as mobile as some of our people, First Nations people in the Northern Territory. I would argue that they are pretty mobile. They get on boats and go to different islands. They do move around. They've got a collective, you know, culture, just like First Nations, where you can pretty much, First Nations Australians, where you basically, you rock up to someone's house and they have to find a bed for you for the night, which is a lovely part of their culture, but unfortunately, you know, it's tricky. So I'm really interested to see how their ivermectin trial goes. I would really, really be very excited if we could do an ivermectin mass drug administration trial in the coming years. But yeah, I mean, that's scabies. What are we going to do about antimicrobial resistance in bacteria? Because that's also a huge problem with overcrowding. We need better housing. We need better services for Aboriginal people.
Sonja, it's I was very, very, very struck by a talk from Jonathan Karapidis when he talked about his, I think it was was Telethon Kids. I can't remember the group that did it, but they spent a relatively modest amount on housing and reduced hospital admission by 50%, just by fixing their, you know, the heating and cooling and plumbing and electricity and everything else. It was really quite striking to me that, you know, the fundamental challenges are really the social determinants of health here, which will have flow-on effects across the communities, and really probably underpin where we need to be going with this, right? I mean,
yeah, 100%. 100%. We need to be investing in people's houses being appropriate. You know, people shouldn't be, there shouldn't be 5-6 kids on a mattress on the floor. You know, people should have dignity and be able to wash themselves and not live in overcrowded situations.
yeah, it's very, very striking. That's, yeah. Anna Shree has got a question. As a veterinarian, I've been transiently irritated by canine scabies. Oh, Anna, thanks for that information. Do you know how ivermectin resistance varies between canine and human scabies, particularly given mass administration of ivermectin to dogs in many remote Northern Territory communities? Great question.
That's a great question, and I don't know the answer. I do know that the genomics of dog scabies and human scabies is different. So there's not thought to be, you can't get scabies from your dog, thank goodness. But yeah, I don't know about ivermectin resistance in dog scabies, but I think that's something that I should learn about. Now I'm getting more and more interested in this particular space. Thank you for your
Yeah.
question. Sorry, I don't have an answer.
Thanks, Anna. Yeah, it would be like you said, it can't transfer between dog to human, but with the mechanisms of resistance, are they similar?
Yeah.
It is it is really interesting, isn't it? Where these programs of health where they're, you know, metaphylaxing entire communities here in Australia, and then even in, you know, in the African communities with the azithromycin and things like that. It's interesting to know or what to expect, and some of those studies have been going on long enough to perhaps see signals in antimicrobial resistance. However, typically the communities where these things are happening are typically the ones that don't have the infrastructure to appropriately monitor it, and probably would be relying on research organisations and NGOs. So it's this real challenge, isn't it? Balancing these real life studies in the use of these drugs as metaphylaxis agents versus the impact on ecology, and it's a balance, isn't it?
Yeah, I really like that paper that came out a few years ago about it, looking at pneumococcus resistance post azithromycin mass drug administration for trachoma, and just showed that the penicillin MICs were slowly creeping up in the pneumococcus. So there's just all these, yeah, you know, as you say, the unintended consequences, and difficulty knowing exactly sometimes what we're doing when we're doing big, broad brush strokes.
Well, I will be at the One Health table tomorrow around the new CDC, and maybe that'll be a question I'll pose around how, if we have these interventions in the community, are we fit for purpose in terms of being able to monitor the consequences?
Yeah, really pertinent question. Thank you.
Oh, we're over time.
Yeah.
I'm very happy that I got back to see the rest of your talk, Sonja. So thank you so much, both Sonja, Thomas and Amy, for this morning. It's been fantastic presentation. Very much enjoyed them, and we are looking forward to promoting them as well through social media so other people can jump on and listen to. Thanks, everyone.
Thank you. It's been wonderful. Thanks very much.
Yeah, thank you.
Thanks, guys. Our next journal club will be a week later, the Wednesday, the 26th of April. So myself, Kaz, our clinical director, Rod, and our guidance implementation lead pharmacist, Nanha, are off to ECMID. So we'll be presenting some highlights from the conference. And obviously any of our participants online who have also attended, either online or in person, are welcome to, you know, contribute and provide commentary for the journal club next month. See you all then. Bye.